Okay, hi everybody. Welcome to CADIO's webinar series. Today we are so happy to have Dr. Jamie Lachman with us. Dr. Jamie Lachman has over 20 years of experience developing, testing, and scaling up family and parenting programs to reduce violence against children and improve child well-being in low and middle-income countries. He is a senior research and teaching fellow at the University of Oxford Department of Social Policy and Intervention, honorary associate professor at the University of Cape Town Center for Social Science Research, and co-founder and CEO of Parenting for Lifelong Health. He is currently leading the Global Parenting Initiative, a 5-year study aimed at promoting research, innovation, and advocacy for the scale-up of evidence-based playful parenting programs in the Global South. The programs and resources that Jamie has co-developed have reached over 210 million beneficiaries in 198 countries and territories. He is also a storyteller, banjo player, songwriter, facilitator, and clown. Dedicated to promoting our human capacity for peace and laughter, Jamie strives to live each day fully with compassion and amazement. And thank you so much, Dr. Lachman, for being here with us today.
Thank you, Jillian. It's such a pleasure. And as I said to you guys before, it does feel in a way coming home. It's just such a wonderful opportunity to share some of our experiences and lessons learned applying the MOST framework to improve the delivery and impact of parenting interventions in the Global South. I was first introduced to MOST by Professor Patty Lighton from the University of Amsterdam, who scratched down the kind of basic optimization trial design on an envelope on the back of a napkin while at the Society for Prevention Research annual meeting one year. And I was hooked from then, and then attended Linda Collins's workshop in DC, and I totally drank the Kool-Aid and have been really so inspired by the work that Linda and colleagues have been doing around MOST and trying to bring it out to the world in terms of and a cost-efficient and effective way of developing and optimizing interventions. So I'll be sharing some of our experiences today, looking at giving a little bit of a background, and then 2 case studies of how we've applied MOST or parts of MOST in both Southeast Europe and in Tanzania, one with an in-person program that we developed with Parenting for Lifelong Health, and the other with an app that is for parents and adolescents, and then some reflections, and then hopefully we'll have time for a bit of discussion at the end. So just as a bit of context, and we know that like 43% of children under the age of 5 years old living in the Global South, low and middle income countries, are at risk of not achieving their developmental potential, and that 1 billion children, that's half the world's population of children, experience some form of violence each year, with many other families struggling to meet the needs and demands on parenting. And COVID-19 showed us all how essential parenting programs are. And why? Because, you know, the consequences of harsh parenting on children are both short and long term. And we've seen through extensive longitudinal and other studies looking at how parenting and abuse and violence against children is linked to poor mental health, poor child development, and school failure, higher risks of youth violence and risky behavior, poor maternal and child nutrition, and also the intergenerational transmission of violence against children, and also violence between partners, so that children who are experiencing violence and adverse experiences and as children are more likely to either be perpetrators or people who experience violence as adults. And all these outcomes are hugely costly to systems and to countries. But the good news is that there's a lot of evidence and knowledge on how to improve parenting skills. And we see this as a logical choice for early intervention. And the evidence has been growing over the last decade, especially in low and middle income countries, where we're seeing a huge rise of randomized controlled trials testing the effectiveness of parenting programs to reduce child maltreatment and harsh parenting, and also seeing how they can improve child cognitive learning and social development. And really, like, the evidence is quite wide across, you know, working with effective for both younger and older children, and across different disparities and minorities, and families with children who have developmental and mental health conditions. interaction. So the evidence for parenting programs and in-person programs in particular is very strong. Just for those of you who are not familiar, when I use the word parenting program, what that is, the way that we define it is that it's a structured intervention directed at parents and caregivers with the aim to improve parent-child interaction and the quality of parenting that child receives. So also they try to reduce harsh and abusive parenting, and also give parents the skills to reduce and manage difficult child behavior. And they focus, and this is really important, on parents learning and practicing new skills and behaviors. And a lot of the evidence-based programs that we look at, when you look at the actual components to them and the content inside, they're very similar and based on the very similar content and principles, with social learning theory and attachment theory being the two main kind of theoretical foundations. And you'll see this with parent management training, incredible years, Dia, strengthening families, Triple P, and parenting for lifelong health. And most of these programs tend to be delivered in person, often to groups of parents, but they can also sometimes be delivered in home and sent by a center. And you can see already, you're hearing maybe some different types of components that are related to the implementation of these programs. The settings can be within schools or daycare, clinics, churches, whatever, the different places where parents can congregate, even in workplace. And often we've seen that the programs tend to be between 5 and 10 weekly sessions, around 2 hours per week. And our component analysis within meta-analyses have seen that and meta-regressions have shown that longer programs do not tend to be more effective than shorter ones. Mostly they're about 15 parents, and this allows for that active learning and engagement and collaborative approach where parents have that opportunity to practice skills, reflect on them, discuss them, refine them, and then practice some more and get that support from a facilitator who is helping them become problem solvers in their own right. And so when you look at the theoretical framework for parenting programs, they have this core components of behavior management, stimulation, relationship building, and stress reduction that may be linked to different proximal outcomes around harsh parenting and reducing cognitive development, increasing parental involvement, and reducing reactivity and stress, leading to reduced child behavior problems and maltreatment and improved child development. And this is one way to think about them. It's just the content within the program, but really it's very essential that we think about the programs and the wider context of how they're delivered. And so then we start thinking about what are the ways that we can engage parents into programs, and the different kind of implementation components around communication and participation, or the training and support that you provide to parents, and those leading to the actual uptake of the content and the components, but also the need to sustain program impact. And we've shown that a lot of programs between 1 year and from an immediate post-test to 1 year later show a drop-off of effectiveness. So the problem is, with all that evidence, we don't really see the scale up or rapid uptake of parenting programs around the world. Well, in a global status report by the WHO to prevent violence against children, found that only 26% of governments actually say they're reaching all parents who need it. And even that number is quite a kind of suspect number, because they're saying they are, but the evidence is that maybe they're not even. And we look at the rates of violence against children. And a lot of this is because of prohibitive licensing fees and training fees and restrictions of adaptation for proprietary commercial programs, where they can't be that uptake is constrained by licenses. But there's also limited financial and organizational and human resource capacity to deliver the program. Sometimes the programs are too complex and so the implementation is also suspect. And also, and this is something that I've learned a lot in my career of doing a lot of testing of programs in RCTs, and then finding that it's struggling to get the uptake, is that the versions that we test in randomized controlled trials may not always be that scalable version. They might be too costly or complex to deliver with fidelity. So in response to some of those challenges, in 2011, we founded the Parenting for Lifelong Health initiative with the World Health Organization and UNICEF. Since then, it was with the aim really to develop, test, and disseminate freely available parenting programs in the Global South, where there was a limited number of those back then. And since then, we've conducted 15 randomized control trials, testing the effectiveness of these programs. Just last year, we established a charity to support the ongoing delivery of that. And the programs have actually been delivered in over 38 countries in a variety of ways for the suite of original programs focused on infants, young children, and teens. And now there are in-person programs, remote, digital, and hybrid delivery as well. And what we've encountered is similar challenges in taking those programs to scale. I mean, the largest example of the scale of a Parenting for Lifelong Health programs is 70,000 families in Tanzania in 2021, which is still scratching the surface of the need in that country. They're still too expensive, they're too intensive and too complex, or they don't fit the delivery system that we're trying to scale in. Or sometimes we also find, especially with the digital technologies that we're starting to adapt to, that there's limited engagement in them. And so if we think about the problem, we know that parenting programs that are in-person parenting programs work. We have so much evidence over the last 50 years of that, but they tend to be too expensive and human resource intensive. And so they have limited reach of impact in this current delivery model that we're looking at. And the big question is, how do we maintain that impact at scale when we are reducing the type of delivery of resources? And so this is where we're really looking at for the last few years, but into the next decade, of like, how can we shift the frontier of cost, reach, and impact while maintaining that impact? And I think this is where the MOST framework can be applied with great use as an efficient and effective way to answer that question, to optimize scalability and impact. Now, I'm not going to break down all these phases because I know that you all are very familiar with this, but I'll show you through the doing of how we've applied this using these two case studies for MOST to optimize parenting for lifelong health. One is the RISE study in Southeast Europe, and then also the Parenting for Lifelong Health program, Parent App for adolescents and teens in Tanzania. So the program, the RISE study in Southeast Europe had the aim to adapt, optimize, and test the Parenting for Lifelong Health program for young children. And this focused in North Macedonia, the Republic of Moldova, and Romania. And the main objectives were to determine the economic impact of the program, the cost for future dissemination and scale up, to evaluate some of those key barriers and facilitators that impact the prevention of child behavior disorders as our main outcome that we were trying to optimize for. And then also identify socioeconomic and contextual factors of relevance. But the key element here was that we weren't optimizing the content, but rather an implementation science approach to this. So we're looking at optimizing implementation factors that, or optimizing a delivery package through testing different implementation factors. And this is part of a team of other colleagues that I was working with in many different universities. And so I just want to also recognize that this isn't my work alone, but it is a collaboration of its own. And we were focusing on the Parenting for Lifelong Health program for young children, which was originally developed in South Africa. It's a group-based program for parents of children ages 2 to 9 years old, using social learning theories to promote positive parenting behaviors, nonviolent discipline strategies, and caregiver stress reduction. It's delivered mostly by community-based facilitators, including social workers, nurses, teachers, and volunteers. And there were two versions that we have tested in randomized control trials. One was an 8-session, originally was a 12-session version in South Africa, and then an 8-session version that we tested also in Thailand. And it uses the HAMP model, the two-stage model of really supporting positive parenting by focusing on quality time and social emotional learning, praise and rewards, positive and reinforcement and positive instruction giving, then helping parents learn nonviolent discipline strategies. So very much similar to your Triple P, your parent management training, Oregon, or your Incredible Years programs as well. And the RISE project had followed the MOST framework as much as we could to a T. So we had a preparation phase where we were testing the feasibility of the intervention. Then we had a optimization phase where we were doing a cluster factorial experiment, and then followed by the evaluation phase, which was a multi-site randomized control trial of the optimized intervention. And this happened between 2018 and 2021. So when we get to the preparation phase, the real purpose was to test the feasibility, able to conduct the assessments and deliver the original intention in each country site. So the question was around, can the intervention be delivered with fidelity? Can we test the fidelity of the short version of a program as well? So we looked at the 12 session, but we also tested a 6-session version as well to see if that could be delivered by facilitators, and also looking at how to adapt it and examining those issues of acceptability, the barriers and facilitators to participation, and other barriers that might come up, when you're thinking about contamination of experimental groups. Also looking at how together through the team build that conceptual model that then we were going to use within our optimization trail. And what we found was that the program was feasible and acceptable in these countries, especially with families with high risk. And we also were it was feasible with the different variations of length of the program. We also found that the attendance and engagement, especially for poorer families, was vulnerable to many different external factors. And that could have been because of poverty, but also lack of low levels of literacy, the fact that many parents had part-time work, or on summer holidays, you just couldn't deliver anything. So some of these external factors need to be taken into consideration. We also found that in order to get a strong quality of delivery, supportive supervision using video feedback was necessary, or at least we thought so. And this is something we wanted to question in our optimization trial. And then also that sustainment in the program required that engagement and commitment from people delivering it. So when we developed our conceptual model, we thought of, well, what were the kind of different types of implementation components that might have an impact on the participation into the program, but then also more proximal outcomes. And so you can see here our conceptual model looking at these 3 components, one of them looking at basic or enhanced engagement package. So the basic was just providing a little snack and also transport. Otherwise, it was enhanced one that also had around text messaging, a more enhanced lunch for the families, and things that would be had quite a cost implication, but would provide hopefully an improvement in the participation rates. We also looked at testing the length of the program, whether 5 versus 10 sessions, and then knowing that that structured video feedback supervision, while the theories would promote that it was very important, we knew that it was a very costly and very human resource and time resource component. So we also wanted to test the difference between a structured and requiring that to happen for facilitators versus an on-demand, so facilitators could receive it if they felt that they needed it. And when we looked at our hypotheses, we would hypothesize that the enhanced engagement package compared to the basic one would result in a higher participation rate of parents, i.e. the attendance, and that this would then result in improved primary and secondary outcomes via indirect effects. When we look at the component around length, this was that we think that those receiving shorter programs would have a higher participation rate because it'd be easier for them to commit to than those having a longer participation. But we also thought that we hypothesized that the groups receiving 8 sessions would have higher dosage compared to the condition than the 5 sessions. So we didn't really expect much difference in our hypothesis when it came to length. And then with fidelity, we thought that the structured supervision would result in a higher program fidelity, which would then result in larger intervention effects, both on the primary and secondary outcomes. So when you look at how we did this in the cluster factorial experiment, we had 3 countries with 48 clusters. So there were 6 clusters per condition. And you can see the conditions here. And we also were doing a cost effectiveness analysis too. So the parents were parents of children between the ages of 2 to 9 with elevated behavior problems. We had 835 participants at baseline and then an 82% retention at post-test and follow-up. We had self-assessments were at baseline, post, and follow-up, which was 6 months after pre-assessment. And our primary outcomes were the aggressive behavior with the CBCL, dysfunctional parenting, which was with parenting scale, and then also the positive parenting, which was a parenting of young children scale. So now if we start looking at how the data analysis, we used effect coding, which was recommended through the literature around optimization trails due to the factorial design. And we looked at treatment effects were estimated using analysis of change approach with baseline data adjusted. For missing data treatment, we used FIML, and then we also set for our factorial results because we wanted to make sure we weren't missing 16 possible effects, we set our p-value at 0.10. We considered covariates and clustering in our analyses, and we tested both indirect and direct effect models based on our models and theories of changes. We can now get into our decision-making process. So here we have our published decision-making process, and we did this in various stages. So the first stage was to think about, well, what is the component level? Which component level is effective? So especially on primary outcomes. So if there was a differential effect for the specific component level, then this component level would be included in the final intervention effect. We also looked at the interaction effect. So if if we didn't see any differential effects, we'd examine potential interaction effects between the components to see if that specific component level had a synergistic effect on this effectiveness of another component. For instance, we weren't so sure that there may not have been any differences on outcomes of conditions receiving 5 or 10 sessions, but it could be that there might be a synergistic effect where the engagement boosters and program lengths resulted in larger effects. So when we look at our effects, and this is now just looking at our post-intervention effects, we found that there were no main effects of any of the components on the 3 primary outcomes. And you can see that here when you look at the length, engagement, and supervision. But we did find an interaction effect. And this is one where we're seeing that the inclusion of supervision showed the length of the program. So this is the longer version of the program. With supervision had a higher effect on reduced dysfunctional parenting. But then at follow-up, we then are seeing that we have a main effect on supervision, but for only one of our main primary outcomes. So we saw that the structured supervision predicted changes in positive parenting from pre to follow-up. And we also found that there are interactions between the length of engagement on pre-follow-up changes in positive parenting and dysfunctional parenting. And also that there was an interaction effect between length and supervision. Oh, I already followed that one up. And so when you're looking at this, we're finding that the length and engagement boosters seem to have a stronger effect. So the longer program with the engagement boosters had a stronger effect on the parenting and the dysfunctional parenting and positive parenting at follow-up. But, and so we also looked at participation in our model to see if that would have an effect on the mediator. And in all of our models, we found that engagement and length, so higher levels of engagement actually had a negative impact on participation rate. And I mean, higher levels of engagement had a positive effect, but the longer program had a negative impact on engagement. So and these were also then indirectly led to changes on positive parenting. We also then looked at the distal outcome variable of child behavior aggression and found that there was also this relationship between positive parenting change and child aggression change was also found. So if you were going to stop here, you could then say that there was interaction. We found some interaction effects, and then we could have gone straight to including our final intervention package. But it was very important that we also considered cost as one of our areas in our decision-making process. And so here we were looking specifically on the CBCL aggression score, and we were really looking at where or what combination would dominate in costing. And so here you can see with the cost effectiveness analysis that looking at the different combinations of components, that the lowest level of components was the one that dominated and was the most cost-effective approach. So if we would go back and think about this in summary, we found that there were no main effects on the primary outcomes at post-test and only that structured supervision at follow-up. So it was really like not very clear. It wasn't like, we got this and now, the optimization trial is showing us based on our decision-making process, we really had to make some decisions here because it wasn't quite clear because we didn't get it across all of our primary outcomes. And maybe a lesson learned from this is to have only one primary outcome that you're really trying to optimize for. But we did find those interaction effects from baseline to post, but not with the main effects. And so this is kind of a marginal significance for decision making. They did have the shorter program predicting higher participation rates, and the higher engagement boosters also predicted higher levels of participation and retention, which weren't our outcomes. And maybe you could argue because we were trying to optimize implementation outcomes that are really proximally linked to those kind of participation and implementation outcomes. Maybe that's what we should have been kind of creating our decision-making criteria on. But when you look at the actual behavior outcomes, we didn't see those unless you go through participation and retention. And that the cost effectiveness analysis favored all of the lower component levels. So when we came to our final selection, we then reverted to the decided to revert to the lower component level for all of those. So this was the 5-session version with the supervision on demand and the basic engagement boosters. Now, a different kind of decision-making process might have led you to go towards, if we go back one, towards the programs with a structured supervision, because we did see that as an impact on positive parenting, or because of the interaction effects, you might have decided to select for that enhanced engagement. But we really wanted to stick to the way that we decided to optimize around our decision making. So then moving on to the evaluation phase, we were conducting a multi-site RCT with the same inclusion criteria collection across the different countries. We're looking at children between the ages of 2 to 9. And also we did assessments of at baseline and also during. So we did these parenting daily reports on behavior and positive parenting at immediate post, or really 1 month post, and then 12 months follow-up after pre-assessment. The control condition, and this is something we debated quite a lot on what we were going to control. We decided that the parents should get the same information so that we can really highlight the differences between the kind of engaging parents in the learning process versus just providing them with info. And the big thing that I'd like to stress here is that originally, and what we optimized this intervention was for an in-person delivery of the program. But because of COVID-19, at the last minute, we had to shift everything to remote delivery via Zoom. And so one could argue that some of these decisions that we made, or the findings that we made from our optimization trial, might not really hold true in the Zoom-based delivery, because the whole implementation was different in terms of learning how to deliver via that platform, and also, you know, the different kind of incentives you might need for participation into those, and also the different time span, the attention span for families. Maybe shorter versions of the program is shorter sessions, but many more sessions would have been more helpful, but we don't know. So we kept with our optimized design. And so I'm just going to run through some of the results that we found. We found some initial positive results based on changes in daily problem behavior based on our parent daily report. So you can see here at baseline, and then down to at time point 3, which is at the end of the intervention. So this isn't at follow-up, but this is at the end of the intervention. So within the intervention, we were seeing some really nice trajectories within the Parenting for Lifelong Health group. But then when we started looking at the results on the main effects of the results, at post-test, we found small effects, but they were significant. But these washed out at 12 months follow-up. And you can see here where we're seeing both groups are even controlling for baseline. Both groups are improving or reducing their child aggressive behavior. And this kind of washes out at the follow-up. And you'll see that we had very similar results for positive parenting, where we're finding small but significant effects at post-intervention, but not at follow-up, and the same for dysfunctional parenting. Whereas with parenting stress, we didn't find any of results in post-intervention, but a 12-month follow-up, we were finding significant effects. So you can see here with parenting stress, where the PLH group continued to improve, where the lecture group had a bit of a regression back to where they were at baseline. But within both the dysfunctional and the positive parenting, we're seeing very similar results where both groups are largely getting better. And so, you know, to summarize, you had seen that with both interventions, we got positive results for the daily report of effective parenting within the intervention, but this isn't really holding for long term. So at post-intervention on most of the primary outcomes, the results are favoring PLH. And the latent growth curve analyses that we were supported more change in parenting for the PLH compared to control, and that these results were stable for the PLH groups from post to follow-up, but the control group also started improving by then. So it's very mixed at follow-up and weak for our secondary outcomes. We did also look at intimate partner violence and found that that also showed an effect at follow-up too. I just didn't show that in the results. And so, these taken together, you could say that the results might have demonstrated some change from baseline to post-assessment favoring PLH group for primary outcomes, but very few at 1 year follow-up. And that the parents in the lecture condition and the PLH condition improved across the range of outcomes. So really you kind of think about the different reasons. It could be because of social desirability based on parental self-report. It could be that the intervention showed some promise in a short term, but needed more to sustain its impact. Or it could be that, a 5-session version delivered via Zoom is very similar to a 1-session lecture via Zoom. And so the comparison might have not been extreme enough. Or it could be that the intervention didn't work. So these are all many different things that we're trying to parse out as we're working on our manuscript for publication. So I want to shift over to Tanzania, where we were working on optimizing a app for parents of adolescents. This was delivered from the Parenting for Lifelong Health in-person program, really taking the content from the program that we tested in South Africa and had been being delivered in Tanzania for 70,000 families in the in-person version. And so we were now moving this into an app, and we created it with a host of different partners, both tech development, implementing partners, facilitators, and direct engagement with caregivers and adolescents in 10 African countries. It was designed for an Android mobile application for offline use. So you could download the information on that, but you didn't have to rely on internet connection to engage in the content. And this was really important for rural areas where we were developing and testing the program, and also for families that might have limited access to data in poorer countries. It was structured around 12 weekly parenting workshops. There was on-demand content and also home activities that parents are encouraged to engage in, relaxation exercises, and also a habit tracker on how they could get parent points for doing different activities in a kind of gamified way. And this was led by a large team, mostly by Professor Lucy Kluver and also doctoral student Rosalinda Janowski, as part of our global parenting initiative that we're working on together. And when we think about this engagement with digital interventions, we know that, with the in-person, but also digital, that we're not going to see the positive outcomes unless we optimize for engagement. And most digital apps only get between 0.5 and 28.6% of completion in real world settings. And a lot of them tend to go to the lower end of that. We found in our early piloting during the preparation phase of Parent App that digital-only delivery had poor engagement. And you can see here on your right, the graph where we're seeing that there's a large dropout of engaged parents as the weekly workshops went along, and a higher rate of those who didn't engage. There were some that were strong, and we were able to do some qualitative research around that. And so we've started to think about how can we optimize user engagement, and what are the different levers? We have some internal levers within the actual design of the app. So gamification, personalization, the structure of the app, the sequencing of it. But we also thought of different things that came out of our qualitative research and our design process, and that were external barriers to engagement. And this was around digital literacy, the need maybe for remote support from a facilitator, maybe in-person sessions that could help, or embedding it within a system. And so both in this study and then other studies where we're working with digital parenting programs, we're really looking at how can we test both the internal and the external. And so this is also very much following the MOST approach, where the first part, which I just kind of summarized, looked at the development and adaptation of the app with user testing interviews in 9 countries, a feasibility pilot in South Africa, and then a pre-post pilot in Tanzania. Then we moved on to the optimization trial, which I want to focus a little bit more on in this talk, which was a cluster randomized factorial trial with 614 caregivers, where we are testing 3 components, which I'll describe in a bit. And now we're in the middle of the evaluation of this, which is a cluster RCT of that optimized intervention. So the goal of that optimization phase was to identify the most effective, cost-effective, and feasible or acceptable combination of component levels that could be evaluated in a randomized control trial. And the 3 factors, we had 2 that were external to the app and 1 that was an internal design consideration or component. And the first one was looking at guidance. So looking at whether external guidance, and a lot of systematic reviews and meta-analyses seem to say that parenting programs can be effective, but they tend to be more effective if there's an external human support for the people engaging in those programs. So this was testing whether we had WhatsApp groups or a self-guided with no additional support. The second factor that we were looking at was around the design internally, whether the sequential, so this is where it's ordered and everything had to happen in a certain order that the program was delivered, or a non-sequential, which was a more like a free choice version where parents could choose based on their preferences and goals. And there's some argument for the non-sequential version being one that parents might engage more because it's directly providing to their motivation and desire to engage. And then the third factor was around digital literacy, and where we had a basic versus an enhanced. So the on or the enhanced version was digital literacy support that was very much engaged in looking at how to use a device, all the different parts of the engaging in the app, and as a kind of preview or an onboarding session, whereas the basic or the off version was looking just on how do you download this app onto your phone or your device, how do you get into Google Play Store if you don't have that. And so that's the basics of just to get it into the program, but not how to use it. So this was our cluster factorial design. It was a 2x2x2 design where we were testing self-guided or guided, non-sequential or sequential, or enhanced or basic. And if we look at the conceptual design here, we're really thinking that the component around that guided support would have an impact both on social support, but also on the knowledge and skills and helping parents learn those and their motivation to engage into the app. And the app design also, we hypothesized that would have an impact both on having the non-sequential might have an impact on the motivation, but the knowledge and skills actually might be the sequential because it's like following the way that the social learning theory goes. And then the digital missed that one line, but then the digital training we thought would have an impact both on the knowledge and skills and also that motivation. And all of these would lead to improved user engagement. So when we looked overall at the engagement, that we found much higher engagement than in the preparation phase. So 98% engaged with at least some of the core content. The average completion rate was about 35% of the program, which is much higher than we've seen in other digital programs. And they performed about 68 actions, which is a lot of interaction. We also looked at the median minutes and the days of enrollment. Most people stayed in like around 31 days. So looking at our primary outcomes here, we found that when it comes to app launches, which is how many times they went into the app and decided to like engage, it's like I'm going in to interact in it. We found that both the that sequential level of the ordered delivery of the workshops had a 30% increase of app launches, and that the guidance, that WhatsApp groups that people could be, had a 187% increase in its in the engagement, but the digital literacy didn't have any impact on that. When we looked at the app design, on the other hand, there was a 29% decrease in the number of sessions that they completed. So actually people didn't go through them as much when they had that ordered delivery and then when they could choose themselves. But we also found that improvement in the guidance here, the WhatsApp groups providing also an increase in completion. And then when we look at the app design around engagement of home activities, So this is like, did they do or say they did the home practice activities that were things that they could do with their adolescent outside of the app? We're seeing that the actual sequential delivery showed a greater decrease in engagement in home activities. When we look at the secondary outcomes, we're seeing similar. So on the time of the app, the guidance also increased. The guided WhatsApp groups increased the amount of time by 45%, also the amount of sessions that they started. And the guidance also increased quite dramatically the logging of positive parenting habits. And this is in the parent points thing. So that guidance and those WhatsApp groups were really geared around getting the parents to actually engage in the app and then getting them to actually apply those skills and troubleshoot with it. We also looked at interaction effects, and I'm only going to really briefly go through this because we are running a little bit short on time, but we found that the combination of guidance and digital literacy had an impact, an increase of on the app launches and on the number of sessions completed. And then we also found that the combination of a sequential approach plus the guidance showed a positive impact, increasing 72%, and also the guidance in combination of digital literacy. So seeing some positive impacts on with the interaction effects. So if we look now at our optimization phase and like our preliminary selection, so we're only here at the effective stage of things because we haven't yet gone to the cost effective. And if you notice here, there is no interaction effects in this decision-making process. And that's because our interaction effects, we were feeling like we were underpowered for them. So we were really using those as exploratory. So here we're at this phase and the cost effective analyses are still pending on the study. And I'm just going to get to the problem here in a second, but which you might have even picked up around. But really here we were saying that the initial findings are supporting that WhatsApp support groups, choosing that higher level of intensity, the basic level of literacy training, since we didn't see anything except for those interaction effects, and then actually the non-sequential choose your own way of delivery of interacting. Even though there was more app launches, we found that when you weigh the other results, that in terms of the actual engagement, that the non-sequential had the better impact. So that's where we are. And if you stopped just on this in your design maker, you would retain that as in your final intervention factor package. So in summary with that, this was one of the really exciting study to be part of because it's one of the first to optimize engagement in a digital parenting intervention in a low and middle income country. And we found that the similar average engagement and retention rates to other digital intervention studies. And one of the more encouraging things was that guided WhatsApp support consistently improved engagement across multiple outcomes. So our next steps, we're looking at like, is there any variation for what and for whom and what, especially with fathers, since we had about 40% of the sample were fathers, which is quite unusual with parenting interventions. The cost effectiveness analyses, which are still pending, and our RCT evaluation, which is underway. So we are kind of going ahead of the, not waiting for the final results of our factorial. I just wanted to highlight two other studies that are ongoing right now. One is to do a similar study in South Africa, where we're really looking at optimizing engagement in a chatbot that is part of the real world delivery of a large scale HIV prevention initiative for adolescent girls in Mpumalanga. And so this is a cluster factorial trial where we're keeping the chatbot on, but we're just testing the differential effect of in-person sessions, either 1 or 4 in person, and those WhatsApp groups that seem to be effective in Tanzania. And then also a chatbot intervention, another optimization trial, with this a pilot one in Malaysia, which is being delivered within the government preschool system, where we worked with government designers and implementers to kind of identify and define what those kind of human resource constraints were about how much in-person contact could you have and how much remote contact could you have. And here we're doing this in just a pilot study. It's not powered, but we're really trying to test. So we're still in really the preparation phase in 8 schools to test these different packages of delivery. So just in reflection, some of the lessons learned before we dive into some questions. Really, like when you're trying to optimize for implementation outcomes, the context really matters, and that context can change based on if then you're trying to take that same results and try and move it to a different delivery context, or because the wider context changes. So for instance, within the RISE project in Southeast Europe, where suddenly we had optimized an intervention, but then we're having to evaluate it. When we got to the evaluation phase, we couldn't deliver it in person. So we really haven't done the definitive test of our results from the optimization phase because we had to move to that remote delivery due to COVID. Another critical lesson that I've learned, and this is something that's not because of poor planning, but because of constraints for donors, and that things really take a longer time, is that we need to allow the time to finish our analyses before moving on to the next phase. And this is really critical if we're going to apply most in a true way. And in a way, I think that two elements could be, one of them is to be realistic about, when you have these funding timeframes, to be able to allow that time to clean and analyze the data and consider the different changes and things like we had in the RISE study. But we did not have that in the parent app time. But the other thing is to think about what kind of outcomes are more proximal, that we could have more immediate and don't have the complicated, that we can make a quicker decision on the results of the optimization trial before moving on to the next phase. And so that's something else to think about. And really critical also is to clarify what is that primary outcome for the optimization phase, and that this might be that you're trying to optimize delivery of an intervention because there's a lot of good or optimize engagement, because there's a lot of evidence that says if you engage, you get good outcomes already in some of these interventions that have been tested widely, but we're looking at new, different, novel ways of testing. So this might be very different. You might want to test for engagement, optimize for engagement, but then evaluate for violence prevention or behavioral outcomes. Also, the fact that what we learned was that implementation, the impact of factorial, the complexity of factorial experiments really had an impact on the ability to deliver for the delivery or the implementation partners. And this is quite critical and sometimes might have an effect on your results. So if it's difficult for them to either keep the different conditions separate or to be able to make sure that they're able to deliver those complex differences. That's really, when you start looking at external factors, those different changes that in theory might be really important, might be very difficult in reality. And then just like we're starting to think about, well, maybe there's other ways of optimizing implementation while you're delivering instead of using only a factorial trial. And it really, as Linda drummed into us at the beginning, it really depends on what your research question is, but there could be multiple or many RCTs or SMART trials, could be also other ways of optimizing that implementation aspect. Just want to thank all the partners that we worked with, and especially the colleagues that I was able to collaborate with on these studies, and our donors and different interagency partners, including the Global Initiative to Support Parents. Thank you very much.
Yes, thank you so much, Jamie. That was so interesting. And we will open the floor now for some questions. If you want to put a question in the chat or raise your hand. And I see that Linda has her hand raised, so I'll turn it over to you.
Oh, this was so interesting, Jamie. Thank you. Thank you so much. I know that one question I get a lot, and you're kind of an expert on this, so I'd really love to hear what you think. What has your experience been conducting optimization trials in low and middle income countries? Do you feel like there are particular challenges that maybe don't come up so much in higher income countries?
I wouldn't be able to tell you if they don't come out in higher income countries, Linda, because I've never done one in
Okay.
So, but I can tell you some of the things that do come up. So one is like even the base of explaining to implementers, especially like, well, we're going to test these different components. They understand the rationale, but then the actual kind of mechanics of like organizing that optimization trial. Another was around training, because we didn't have the funding to train different, like in South Africa, in that trial that we're doing now, different groups of facilitators. So we trained them in the complete package, and then we're like, okay, but you are only delivering this version of the program, and so there was a lot of concern around contamination. And because it's a real world trial, we don't have our fingers on the actual implementation of it. So to track that contamination has been really challenging. One solution that we've come up with for that is in the Malaysia trial that create a facilitator app, so that the information that you are allowed to deliver all is there. So no matter what component, even though you've been trained in the whole package, you get only what you need to deliver.
That is great. I mean, I always tell people use technology as much as you can to help, because it really helps things to run much more smoothly. Another quick question I have for you is, a couple times when you were talking, I felt like, I'm not trying to put words in your mouth, but I felt like you maybe had in your mind more than one outcome variable that you would want to optimize on, but you ended up sticking with one because you were using the component screening approach. Is that an accurate assessment?
I think we wanted to be transparent and stick to what we had decided on a priority. And but what I've learned, I guess, so yes, it was accurate. We had other ideas of what they could optimize on, but when we set up, like, we're trying to optimize for child behavior problems, or for this, when one of my internal critiques of our study in the parent app one was having, 3 different primary outcomes on engagement. Well, which one is the most important? The truth is we don't really know which one is. And linking those 2 outcomes would maybe be something we need to do to understand then which one would we value when we're doing the selection or the screening phase. But one of the things I've learned, and I don't know if you've seen this in other people who've been doing optimization trials, is that it's possible to go back and be like, well, actually, this is, we're not cherry picking to see what is out, but if there was a different reason that your rationale for what you want to optimize on, it might be that, the selection of the screening process might be different. Or if you really value, like, for instance, in RISE, that kind of enhanced engagement package, its impact on participation as an implementer, you could be like, well, I'm willing to spend that extra money to get the better participation. So kind of what I found is, you get the results that you publish, but then when you go to recommend it to policymakers for recommendations, there is more nuance in allowing them to make educated decisions on what they choose to take up and what they don't, because now you have the data on both the impact, the outcomes, but also the cost of those. I think that's
so you could actually re-optimize using that. You need to talk to Jillian, Jamie.
Great.
I'm going to stop now because I know there's other questions, but you need Jillian. You should maybe send him the health psychology paper.
Sure. Yeah, I will follow up and we'll talk about decision making.
Okay.
But for now, the question in the chat is, what will be your future steps and what is your big hurdle in your research? That might be a big area to talk about in just a few minutes, but maybe you could pick a future direction and or a hurdle.
Well, I think, so one of our big future directions is to learn about, like, when these digital interventions go into the real world, can we apply the same kind of optimizing techniques that, like, Facebook does to get you to be addicted to, like, scrolling and stuff, to doing that? And I think that's going to be something that's quite interesting. Right now, we're still in the controlled experiment, but can we experiment on these to improve and to be more specialized and more personalized? And this, I think we're moving in a little bit more in the mini RCT or the rapid RCT testing version, or A/B testing versions of those. But it may be possible with larger data sets to do more very interesting internal design work around optimization. And then the other big step is around making sure that these interesting questions that we're having are really connected to real world policy and scaling questions that are out there, so that we keep that kind of eye on the prize, which is to really be able to expand the reach and maintain that impact of programs. And so that's a big issue. And that is, the demand is out there. So it's really up to us as researchers to be able to provide that kind of most evidence-based and optimal intervention. And I think that's the hurdle right now, is that these things still take too much time. These studies are taking too much time to meet that demand. And so sometimes you kind of have to be giving your best advice based on the data that we have, but we really need to be doing more of them.
So Jamie, I wish you could talk to our colleague, Dave Van Ness, he's a health economist, and he's starting to do some interesting work that would speed up the most process.
Oh, definitely love to talk to him about that.
Yeah,
Yes.
I mean, it's very early. Probably you should talk to him in a couple of years, because it's very, very early days yet, but
If he
he's got
wants a
some
guinea pig, Linda, who has like a study that we would be really happy. And
okay.
And in fact, you know, like people, I maybe respond to go back to your first question in closing, like maybe I'm finding that the receptivity to the factorial trials and optimization trials is higher in low resource settings because resource is such a constraint.
Mm-hmm.
So if you're like, look, could we do this experiment to see if we can get the same impact or get really good engagement, and it's going to cost your teachers less time? People are like, oh yeah, we'll invest in that time. We'll give you that time because it's such a high policy priority for governments. And I see that's happening in US too, but I think it's more critical where there's even less resources. So.
Well, in the US, there seems to be kind of a denial of the whole idea that there are trade-offs. You know, it's like in the US, we have this fantasy that we don't have to worry about cost. You see it in healthcare all the time too, that you just don't, you know, we don't face that. Okay, sometimes if you're going to reach everybody, you're maybe not going to be able to reach them with the Cadillac version. It's going to have to be a somewhat less fancy version.
Yeah, the public health approach hasn't gone there. Of course, we have the problem too when we have a shiny object sometimes. Then, like, there was a point where Lucy and I panicked during our Tanzania trial because the government was like, we love it, we're scaling it now. We're like, we don't have any evidence that it works. Can you just wait a year of release? So,
yeah.
You know.
Well, that's another thing. I think people in government and education also, sometimes if it looks plausible and it's a shiny object, as you said, they know it's going to make their constituents happy. Yeah. And so that's the main thing they want.
Yeah.
I
really like the recent way we're going, where we co-design with government so that it is their priorities as well. Then we can use the tools that we have as methodologists to answer those questions.
Yes.
Thanks again, Jamie, for doing this for us. We really, really appreciate it. It was so interesting. You got through so much information. It was really remarkable.
Well, thank you. I've learned so much from Linda and Kate, and I look forward to engaging with you too, Jillian.
Yes,
and
absolutely.
Gabby's been such a great organizer of the webinar, so it's been a pleasure.
Well, do keep in touch about your work. We're watching it with great interest.
Take care and be well.
Bye-bye.
Bye.